Hi, Dr. Brian Kaufman, a retired family doctor and a CLL patient myself, and the co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society. And today I'm sharing with you some of the most important papers from the American Society of Hematology's annual meeting in 2024 in San Diego, California. And the paper I'm about to talk to you about was an abstract called First-Line Treatment Choices and Risk of Other Malignancies in U.S. Veterans Diagnosed with Chronic Lymphocytic Leukemia and Small Lymphocytic Lymphoma. The bottom line on this paper is that unlike the situation with chemoimmunotherapy, the new novel oral therapies and monoclonal antibodies do not increase the risk of other cancers in CLL patients when they're compared to active surveillance in those patients. Let's start by saying who performed the research and where it was presented. Dr. Helen Ma works out of UCI and Long Beach Health System, University of California, and she works also in the Veterans System. And she had multiple colleagues, and she presented a poster session at the American Society of Hematology's ASH 2024 meeting. Let's look at why this research is important. Chronic lymphocytic leukemia, or CLL, and small lymphocytic lymphoma, SLL, they're a cancer of the immune system. All CLL, SLL patients are immunocompromised to some greater or lesser extent, and it's dependent on their disease status and what treatments they've had. As a result, they are at higher risk not only for infections, as we all know, as the recent pandemic has demonstrated, but also for other cancers. This trial examines how the choice of frontline treatments, first therapies, contribute to the higher incidence of second malignancies. Chemoimmunotherapy historically was the most commonly used option until the approval of the oral targeted therapies, with the first Bruton tyrosine kinase, ibrutinib, being approved in 2016, followed by acalabrutinib, zanubrutinib, and pirtobrutinib, and venetoclax's approval in 2019, which is the only commercially available oral BCL2 inhibitor. These are now the standard of care for initial therapy, often used in combination with an anti-CD20 monoclonal antibody, either rituximab or obinutuzumab. The change in practice over the last 10 years or so provides the opportunity to study the impact of these different frontline therapeutic approaches and how they might influence the risk of developing a second malignancy. Let's look at the methods that was used. Using the large Department of U.S. Veterans Affairs Central Cancer Registry, a retrospective analysis conducted of CLL and SLL patients during and after 2016 who were diagnosed with a new other cancer. So they had CLL and another second cancer. That did exclude the non-dangerous skin cancers, the non-melanoma skin cancers, such as squamous cell carcinoma and basal cell carcinoma of the skin. What were the results? Well, a total of 5,244 patients with CLL or SLL were included in the study. The average follow-up was a little more than 3 years. The median age of diagnosis of CLL, SLL was 71.7 years, pretty typical. As you might expect from a veterans population, there were way more men than women. 97% of the patients were men, and 78% were white. 3,460 patients, or 2/3 of the patients, were managed with active surveillance, or what a lot of people call watch and wait. The other third of the patients obviously required frontline therapy. Let's take a look at that frontline therapy. 25% of the total patients received a targeted therapy, with the majority, 6 out of 10 of those, taking ibrutinib, followed by 1 out of 5 taking acalabrutinib, 1 out of 10 taking zanubrutinib, 12% taking venetoclax, and only 3 patients in total taking a combination of ibrutinib and venetoclax is part of a clinical trial, so less than 1%. Happily, I can report that only 6% of the patients used chemoimmunotherapy, only 3% used monoclonal antibodies alone. So that's the group that we're looking at. 505 of the over 5,000 patients, or roughly 10%, were diagnosed with a second cancer. And therefore, 4,739, or 90% of the patients, did not develop a second cancer during the 3.19 years of follow-up. What were the cancers that were developed? Well, the most common was lung cancer, found in 120 patients, or 24%, followed by prostate cancer in 21%, or 105. Gastrointestinal cancers accounted for 14%, other blood cancers 13%, melanoma, which can be a very fatal skin cancer if not caught early, was found in 9% of the patients, kidney and bladder cancers in another 9%, head and neck cancers in 3%, and 7% of the cancers they didn't identify or were other types of cancers. As you might expect, more patients who had a second cancer had a history of tobacco smoking compared to those who were diagnosed with CLL, SLL, who did not have a second cancer. But what was surprising is that fewer patients with the second cancer had a history of alcohol use. While adjusting for these risk factors, such as age of diagnosis, tobacco, and alcohol use, patients treated with chemoimmunotherapy had a significantly higher risk of a second cancer compared to those just on observation. The overall risk ratio was 2.4. In other words, they were almost 2.5 times as likely to develop a second cancer. But what about patients treated with the new targeted therapies? And what about those patients treated with the monoclonal antibodies alone? Did they have a higher risk? And the answer is no. The ratios were 1.1 and 1.4, not statistically significantly different from those in active surveillance or watch and wait. Again, not surprisingly, more patients who had another cancer died compared to those without another cancer, 43% versus 27% in this study. That reminds us that with the improved treatments we have for CLL and SLL, more and more patients are dying for other reasons than for the CLL, SLL itself progressing. So in conclusion, it's reassuring to know that modern therapies are not only improving survival for those with CLL, SLL, but they do so without increasing the risk of second cancers. We provide links to the actual abstract on the website and more background information. Thanks for your attention.